And so we're here to learn as much as you want about all the problems that you can run into. And Dr. Kai is here to help us. Now, Dr. Kai is the Chief Medical Officer. He's a board-certified psychiatrist with extensive experience in all areas of psychiatry and medical management. In addition to his duties at La Frontera Center, he's the clinical associate professor at the Department of Psychiatry at the University of Arizona College of Medicine. He's also authored 2 books on the topics of psychiatric education. So Dr. Kai, you're up.
Thank you. Good afternoon, everyone. Can you hear me? Good afternoon, everyone. Oh, it's good. My name is Wenhui, and I am a psychiatrist. Some people call me the shrink, so I say I'm a shrink psychiatrist. And I practice in Tucson. I came to Arizona since 2008, and I have always been doing both the clinical service in the private practice and also the medical management and the community mental health center such as La Frontera. So that's my background. And today I'm very privileged to come here to have a discussion about the psychiatric consequences of the Parkinson's disease. Frequently, we encounter the situation in our clinical scenario that the Parkinson's disease people may suffer from depression, anxiety, impulsivity, psychosis, or memory issues. I'm pretty sure that the audience here already have some experiences from different sides about that. And then you also may have quite a bit of the question as, what is the depression? Is this really the major depressive disorder, as your psychiatrist always call that? Or it is just a normal part of the process? How do I know whether I am good with everything or I should get the treatment? And also the anxiety. Everybody is going to be stressed out with the diagnosis or maybe with the situation. What is the time we need to seek help? What is the normal situation we just need to tough it out? And the more question may be coming from the medication side. I take this medication, I took it for a long while, and I don't know whether that's helped me or not. And all these things I can really give you the input from a psychiatrist's perspective. Before we start, I do want to make a disclaimer. I am here to give the introduction of the knowledge of psychiatric diagnosis and treatment. I am not here to help you to self-diagnose yourself. I'm not here to even direct you with a medication treatment or non-medication treatment. I'm giving you the information. This is information exchange opportunity. For anything you really perceive in the future for yourself or for your loved ones, you need to contact your care provider. Your doctor needs to really authorize and approve every treatment modality. Simply put, I am your Google searching engine. And if you ask the question, what is this about? And I give you the answer. And I'm not as accurate as Google, but I can tell you I have a lot more experience than Google in my clinical setting. So without further ado, I will start with that kind of set. I do hope everyone asks one question. You can ask multiple questions, but everyone asks one question that you think may be relevant to your situation. Here is the information. Before I came to Arizona, I worked in a university setting. And what I did is a study of the memory. It's not about Alzheimer's memory. What I studied is about emotional memory. And what that really had a relevance to is so-called PTSD or post-traumatic stress disorder. What I realized is people remember the emotional memory far better than the cognitive memory. For example, when we sit in the classroom, study for the exam, get a certificate or license, all these things, I can tell you, will be forgotten 2 weeks after you prepare the exam. That's a normal part of the process. That's a very normal part. Don't feel bad about that. Sometimes I joke with my colleagues and my students, I say, The brain actually is like a toilet. You just need to keep flushing it and keep it clean so you can put more stuff in there. If you just pop in there, it can clog, then you cannot put the new stuff and it starts to be smelly. So what I try to say here apply to this audience is whatever I talk, you will forget about it. 80% will be gone in about 2 weeks. If you still remember what I'm talking about, well, I think that you need to let it go, rather than keep remembering that. But if you do remember to ask me a question today, and that question is relevant to yourself, you will get the answer and you possibly will remember the answer for a long, long time. I am here for you. As Sue mentioned, everybody here is a volunteer. We are here for a group collaborative and collective benefit. I am here for you, so do not let the Google engine go by without you hitting a question into the question mark, okay? So ask those questions. Before we solicit the question, I'm sure that some people have more questions than the others. I would like also to say a little bit about the psychiatric condition in relevance with the Parkinson's disease. Parkinson's disease is the #2 neurodegenerative disorder in the psychiatry or neurology field. It is a movement disorder, which I will stay far away from today because you have the high-power neurologist come here, give you the diagnosis, symptomatology, and the treatment choices. That's not my job. My job is in the backside, which is the shadow of the Parkinson's disease. When we have any chronic illness, our body starts to really sync with the chronic illness, and it bothers us. And for Parkinson's disease, beyond the regular chronic disease model, it also has the partial contribution to the psychiatric symptomatology, and it's part of the Parkinson's. But most people view Parkinson as the shakes or rigidity and the gait issue and movement inconvenience. That's what bothers most people on the majority level. But at the same time, people may feel very anxious. The anxiety symptom is 60% with the Parkinson's disease. And minimally 40 to 50% of the Parkinson's disease members will have some kind of depression. And among that part, at least half of that meets the criteria called major depressive disorder. When I say that part, I do want to warn you that the medication treatment could be indicated. That's a key word. Don't say that medication is the only choice, but it can be very helpful. And also, a lot of time, the symptomatology of the apathy. People feel flat, people are not motivated to do things, people just feel blocked. These kind of symptoms are also part of the Parkinson's disease symptomatology. Neurologists possibly will not talk or dwell on those topics, but we do. In addition to that, we frequently, when I was a resident, within the university hospital, what we always do as a psychiatric consultation to the neurology department is the psychosis. The Parkinson's disease patient or regulating the carbidopa, and they have psychosis. They see things which will not do. They sometimes get paranoid. And their thinking process can be disturbing to themselves. They don't feel comfortable. And that's where the psychiatry came in. And also a very big topic, which is the common ground between psychiatry and neurology, which has always been there, is the memory loss. As the disease progresses, then the memory starts to be really have the problem, and that can be either the Lewy body dementia or Parkinson's disease dementia. Not mentioning could be also sometimes without that, at the same time. So all these things can be bothersome. At different stage of the Parkinson's disease, different symptomatology will come on board and bother people in different way. Another very important, and I consider even more important topic today, is for the caregivers to the Parkinson's member. Caregivers and the Parkinson's are actually, I call that, we are on the same boat. And remember when you ride an airplane, the flight attendant always say that, buckle yourself, or if there is a situation that the oxygen mask drops down, you need to put oxygen mask on yourself first. before you put that to your next person. It doesn't matter who next person really is, it's your dear grandson or dear baby, but you need to put the face mask on yourself. Because if you are not doing well, you cannot take care of another person.
So what's the best medication to use when they have the extensive dreaming nightmares and start acting on that?
So the question is, Bob has the Parkinson's disease, and Bob has been having a lot of the active dreaming, and some people call that the nightmare. And it depends on the details of the nightmare or the dreaming. Most of the time, from the psychiatric perspective, we view the active, well, let me retrieve it back, and I will try to do that with every question. I try to give a micro mini review about the topic itself, which I consider to be important, and then I give you the possible answer. Possible, okay? So the dream starts from the sleep. The sleep is divided by REM sleep and non-REM sleep. And when we sleep in the REM sleep, we dream. When we sleep in the non-REM sleep, we do not dream. Every night, the sleep comes with the non-REM sleep and then circulated by the REM sleep and non-REM sleep and REM sleep. The proportion of the non-REM sleep is big at the very beginning, the first half of the sleep cycle, and the REM sleep is heavy duty on the second part. So everybody dreams. I'm pretty sure some people say, no, I never dream. The reason you say you never dream is because you wake up always in the non-REM sleep. You wake up in the non-REM sleep, so you don't remember that. Based on the sleep study actually can wake you up and tell me what are you dreaming about. And so how do you know that? Because they can monitor the REM sleep versus non-REM sleep and wake you up right at REM sleep time, you are dreaming. It's just a normal process. Active nightmare or the active dreaming indicates that people wake up during the REM sleep pattern or REM sleep phases. And a lot of time, the scene of the sleep, the dream is consistent with the daytime stress. If you are very, very happy, you win a lottery, and you had a good time going on in your life, your dream is also positive with its tone, but not really matched with the content. I say the content is always ridiculous and irrelevant from the reality, but the tone is very, very consistent. If you are underneath the stressful situation in your daily life, the person has been depressed, has been stressed out, having been traumatically, suffering from something, the dream is also in that way. The tone of the dream is in that way. We do not have a cookie cutter for the dream treatment, but we do know one medication that has been a serendipity finding by the VA doctor in Seattle many, many decades ago. The name of the medication is called Prazosin. Prazosin is a blood pressure medication. And a lot of VA patients have a blood pressure issue, and some doctors, medicine doctors like to use prazosin versus other, hypertensive medication to treat patients. What has been found is that the group of people who are taking prazosin has far less PTSD nightmare compared to people that take other form of the hypertensive medication. And because of that, the drug company has launched a big study. And what we later on realized is this medication is very effective to treat nightmare that is related to the PTSD. Having said that part, it's not FDA approved, because if you want to get FDA approval, you have to go with a double-blind placebo-controlled study in the case of dose relationship. They did not go through that because prazosin is a medication that has already been in practice for a long time. Nobody wants to pump the money into the market. Each indication costs millions of dollars, if not even more, to get indication. But we all know in the practice field, the prazosin can be a good medication. The dosage of the prazosin comes with the very low dose, 0.5 milligram, all the way to 3 to 4 milligram. But obviously, be careful with the side effect, which is actually the original treatment effect, which is lowering of blood pressure. And taking medication before people do that sometimes take a while to really reduce the frequency and the significance of the nightmare or the vivid dream. I hope that gave you some point. Yes, we have a lady on the back.
Thank you. How do you spell the name of that drug?
Prazosin, prazosin. It's a blood pressure medicine, not very commonly utilized. It's not a beta blocker, it's not a ACE inhibitor, it's not a calcium channel blocker either. It's actually a alpha agonist medication, works in a unique manner. Many times we have the medication that works for physical symptom from one mechanism of action, but they work differently for psychiatry or psychiatric condition. For example, the beta blocker works in the spinal cord and lower the, relax the blood vessel, the walls of the blood vessel. But when they work in the central nervous system, in the brain, that can have a very calming effect. So the same medication may act at different parts of the body and create different results. Give you another very relevant topic, levodopa and carbidopa. That's a very standard treatment for Parkinson's disease. And the reason the neurologists use the dopaminergic medication is because the hypothesis of the Parkinson's disease is because the dopaminergic neurons degenerative process, and in the substantia nigra area, it is lack of the dopaminergic function. And then we have all the movement symptoms. That is one area of the central nervous system that the neurons start to go haywire. When we give levodopa carbidopa, what we really have is a medication in the bloodstream supplied to every part of the brain, not just in the substantia nigra, but also in the other parts of the brain. That's why when people have impulsivity related to Parkinson's disease treatment, not so infrequently, it is caused by the dopaminergic medication because it acts not in the substantia nigra, but in the other parts like prefrontal lobe or the the limbic system, and make people having more tendency to gamble, to have hypersexuality, or to have the money spending spree. And so each medication has its pros and cons. We want to use the positive therapeutic side, but we need to be keenly aware of the negative or the detrimental side. And it's a fine balance when we take the approach to treat people. Yes.
Well, you just hit why I'm here, impulsivity.
Okay.
My husband has always been the poster child for an officer and a gentleman. He is now in daycare 4 days a week, and they have had to call him into the office like he's a bad child too many times because of impulsivity. I mean, he will grab another partner that's, or person that's there and pull her down to sit in his lap, things like that. They're beginning to sound like if it continues, he's gonna be out of there. And I don't know what I will do next if they kick him out.
The topic of the impulsivity, there could be multifactorial etiology related to that. Number one, I will just give you a kind of clinical scenario. Very first question most treating psychiatrists will ask is, has your husband been impulsive and have mood swings before he was diagnosed with Parkinson's disease? So there is a very significant prevalence of psychiatric diagnosis or psychiatric disease in the regular non-Parkinson's disease population. For example, anywhere between 18 to 65 in the normal adult population, 25% of the people will have anxiety disorder. That's a very high percentage of the diagnosis. You are in a bus station, which in Arizona, we don't have a lot of bus riders, but if you're in New York City, you run a subway, and just think about it, look around, 1 out of 4 around you have anxiety disorder. And actually 15% of the general population have major depressive disorder. I'm not talking about being depressed. We have all been depressed. If you tell me you have never been depressed, I can tell you you are not a normal person. But you may not be the major depressive disorder. And what I'm talking about is 15% of the general population. Think about the subway in New York City again. 15% of them have major depressive disorder. This is a very high percentage of the psychiatric problem in our community. And the bipolar disorder is anywhere between 1% all the way to 6%. We call bipolar 1, bipolar 2, bipolar spectrum disorder. So they all have a different level of the prevalence. Prevalence is the percentage of people who has that condition. So if a person has the pre-Parkinson's disease psychiatric condition, we need to treat that as a primary psychiatric condition. We need to find the medication to treat those conditions to the best level we can. Best level does not mean the highest dose of the medication, but means that maximum symptomatology control with the lowest effective dose. Having said that part, many times when I say lowest effective dose, that may not be low dose. It just needs to be not more than necessary of the lowest effective dose. So that's one concept. Second concept is the impulsivity related to Parkinson's disease. Separate from the dopaminergic medication, Parkinson's disease itself is a neurodegenerative disease, as I said, that is dominantly presenting in the nigra, the substantial nigra. But in the other parts of the brain, similar neuropathological process has been going on, and the people start to show other symptomatology. Impulsivity is one of them, even though it's not the highest on the list. Highest on the list is apathy and anxiety and depression. And the third part of the Parkinson's disease related impulsivity is directly related to the dopaminergic medication. Because dopamine is the molecule, the neurotransmitter, that can make people more impulsive, even have psychosis, like the seeing things which are supposed not to be there, and being paranoid, and also have the manic like symptom, money spending spree, and hypersexuality, and like to go to the casino to gamble. And it doesn't matter the result, they just like to gamble. It's not like you win the slot machine, you start to come back. Winning or not is not important, but keep gambling, keep the impulsive behavior is what satisfies. So that's the symptom. And when we treat such kind of condition, very first thing is the clear diagnosis. Second part, as we mentioned, is to fine-tune the dopaminergic medication. There needs to be a balance between the movement control as well as the psychological stability. And the third part is whether we need to add on some medication to modulate their impulsive behavior. And those are discussions that we traditionally call them stabilizer or so-called atypical antipsychotic. And I'm pretty sure that if you're treating a physician will start to say, the antipsychotic themselves can cause more Parkinsonism, so let's avoid that and let's explore the other mechanism of action medication that start as a safe route. So there are a lot of detailed discussion in that kind of a paradigm. But nevertheless, I'm a big diagnostic patient-oriented psychiatrist. I need to know what is the diagnosis and what's the possible cause of the diagnosis so I can give the budgeted effort to minimize the overexposure of the medication for anyone. Because just like the disease itself, medication can cause side effects. And our job is to minimize that as much as we can. Instead of just giving you a medication, do you feel better? And doesn't care about the consequences, either in the days or months or years down the road.
Thank you.
My pleasure. Yes.
My husband is plagued with episodes of inappropriate crying or laughing, and he can't control when it happens. It causes a lot of social anxiety. And can you tell me a little bit about the dynamics of that?
Yes, there are some typical psychiatric diagnosis related to the similar situation. The lady just mentioned that her husband has been having inappropriate laughing or crying. The emotionality is not consistent with the surrounding environment or even with the condition that he is in. And such kind of situation is what we call the prefrontal lobe disinhibition. The person is just becoming inappropriate, and a lot of time it may be having a lot to do with the neuropathology in the prefrontal lobe. I had a gentleman in my office. This is the thing that I still vividly remember. He sits there. He's a very nice gentleman, and he was in his 80s, and his daughter was with him. And there was another lady, the mid-aged lady, sit across the hall, and a very nice lady as well. And this gentleman just said this to that lady, saying that, how are you doing? And the lady said, the stranger lady said, well, I'm doing fine, thank you. The second sentence coming from his mouth was, you have very nice food. You have very nice food. The lady does not know how to engage with the conversation. And then this gentleman spit into the floor in the waiting room. Spit. Everybody was shocked. The daughter asked for the paper towel and clean that, and then whispered to the lady saying that my father has been actually a very high-level executive for airplane company, but this is the recent change. That's why we are here. He is not himself. We don't know what's going on. And what that really shows is a typical prefrontal dementia. Okay, everybody is embarrassed to tell you the truth, except that gentleman and me, because it's a typical situation. And in our education, what we even know is he should not be given the high dopamine blocking agency medication because he will have a lot of side effects. So sometimes we cannot change the course of the illness, but we do know what's going on, and we will try the best we can to support the gentleman and also support the family. Think about how much of the stress the daughter will have. And this is not the first time, but I remember clearly one is the group, one is the state. And my staff member never really had experience to even observe this one, and was just shocked and saying that, how do we deal with this? I said, do whatever you can. Number one, no blaming. Number two, be very supportive and understanding. And then number three, you learn from this. So it's not a very highly commonly seen clinical scenario, but it does happen from time to time. And so particular parts of the brain start to be influenced by that neuropathological process. I'm telling a lot of stories. Any question? So the reason I'm soliciting question is that the more question you ask, the more you remember at least what I tell. And certainly you will also remember the stories. Yes.
Yes, thank you, doctor. Can you talk a little bit about anxiety? And, you know, we all know that exercise is good to decrease that. What other things can you tell me about anxiety?
So the question is a big topic. Tell me about anxiety.
Yeah.
Anxiety is, in my mind, the most commonly seen psychiatric condition in our community. the most commonly seen based on the prevalence. It has been superseded by substance abuse in the recent years, but in the past, it is the most commonly seen psychiatric diagnosis. It is actually underdiagnosed and undertreated. Many people consider anxiety as their personality. I'm the introvert. I don't like to socialize with people. Even though you want to drag me, I will find excuses. Oh, I have the back pain or neck pain, or I just have diarrhea. I don't feel comfortable to go there. So it's very common for people to experience anxiety, but without realizing that. And also, many anxiety people, listen to me carefully, this is coming from the real practicing shrink. Many anxiety people are perfectionists. They do things in the perfect way. You go to the office of such kind of people, they always have the sparkling office. They don't have the piles of the paper or stuff scattered around. They are perfectionists. And also, the anxiety symptom is an episodic symptomology. They are more stressed out when the surrounding environment is changing. When they are living in a consistent, stable environment, they don't feel stressed. So what they like to do is stay in the same environment and continue the same pattern of their lifestyle as long as possible. When such situation happens, they are fine. Frequently, when there are significant changes, they have the panic attack. The heart palpitating very fast, their hands are shimmering, and they cannot speak, and they stutter, and also they have migraine headaches, and they feel that they have heart attack, and they may even have seizure-like activity. They go to the restroom frequently, and they may have diarrhea and constipation. So all these symptoms are part of the anxiety. The regular so-called generalized anxiety are the anxiety that they have the stressful situation, they have the headache, they have the muscle tension, they cannot sleep well. They dwell on the things over and over. And at the same time, they are worried. They worry about things. I always joke with people saying that, let's say you need to move from, let's say, Green Valley to South Arena. Are you going to be worried about where you are going to be living at, which block are you going to be staying at, and what's your neighborhood grocery store? And a lot of people say, why do you care about that? There's always a grocery store somewhere, right? And there's similar things going on in Southern Arizona. But anxiety people say, yes, I want to know every detail. Most anxiety traits start to develop itself from the young age to the middle school age to the teenager, high school age, progress into the adulthood. As we get more into the adulthood, we get used to the setting and we become part of the style that belongs to ourselves. The treatment of the anxiety disorder, more frequently than not, is with behavioral treatment, exercise. That's what you're talking about. Exercise has significant benefit in every perspective, not just to strengthen your bone, not just to give you a healthy heart or lower your blood pressure, but it pumps out endorphin. Endorphin is a happy neurohormone or happy neurotransmitter. When you have a lot of the endorphin, you don't feel the pain, you do not feel the depression, you do not feel the anxiety. So exercise is very helpful. I don't see Charlene here, but I emailed her saying that, tell me about how other people talk in this conference, and she referred me to the YouTube. And I did not really see any presentation, but I see a lot of exercise clips from this organization. And I can tell you, I wholeheartedly support such kind of a, approach. It's not just for movement disorder. It's also going to be hugely beneficial for psychiatric symptoms, particularly the top two, the anxiety and depression. For the regular anxiety treatment, number one is with we call CBT, cognitive behavioral therapy. We call that the talk therapy. And that can be quite effective if you apply that to the right setting. And that does need specialized services and provided by the therapists. Second part of the treatment is the medication treatment. Medication treatment can be very helpful, but I would like to say if you have mild anxiety, if my own family member has mild anxiety, I will engage them with the therapist instead of the medication. If you want me to dwell into the medication, then that's a lot of I can do possibly 50 slides presentation on that part, but that's a summary of that part. I want to mention two things about medication without detail. One is the addictive medication called benzodiazepine. They can be very effective, so effective that make you fall in love with them. I call them the high interest credit card, because once you take them, you find that it's so easy to use, but then you keep using it and you cannot live without it. Stay away from them when possible. Second is antidepressant. And you will say, antidepressant, I'm not depressed, I'm just anxious. Antidepressant are also the medication that FDA approved for anxiety, and 57% of the anxiety people have comorbid depression, and that is one stone for two birds. But there are tricks in how to select medication. In essence, exercise, socialize with your friends, with your colleagues, and go to the meetings like this, and be part of the community, and along with the physical exercise to pumping up your endorphin is going to be very helpful. Yes.
I'm coming. Where are you, sir?
The depression, the MDD, and the anxiety were actually the symptoms that Bob had before we knew he had Parkinson's. So what we have thought during his Parkinson's diagnosis, and he's gone from Parkinson's to Parkinsonism, to Parkinson's, to Parkinsonism. He will be going along with MDD, just, basically getting along. And then he'll have a nosedive. And the apathy is what will keep him in bed for days. He can't get out to exercise. And so I dove into the medical literature. And what I found is that there are two things called Parkinson's depression and Parkinson's apathy that are not MDD and are not just plain apathy. And it was helpful to know that. And then it was helpful to know that there were medications specific to that. Cymbalta was one, and I don't like Cymbalta because of trying to get off of Cymbalta. And the other one was Wellbutrin. And that has been more helpful than just about anything else he's taken. Do you know anything else to help with the apathy when they can't get out of bed to exercise?
So let me come. Thank you for the question, and that's a very big topic actually. I want to mention a few things. Number one, apathy is one of the very debilitating psychiatric symptomology among Parkinson's disease members. Very, very debilitating. Number two, with or without major depressive disorder, apathy is a poor prognostic factor, meaning that the person has apathy, their outcome generally will not be as good as the people who does not have apathy. So if there are opportunities for us to fight with apathy, I give you wholehearted support. Okay, so that's one thing. And then number two is, you are very correct, you read a lot. The Parkinson's disease itself, part of the symptom can be mimicking the depression, or basically they have depression elements. And the apathy is not consistent just with the depression, but also has its own flavor of the depression, but it's majorly the flat affect, no motivation, not enjoying the fun thing in their life that they enjoyed before. The two things can be part of the Parkinson and also can be separate from Parkinson. So she already, actually, I call that, had a very accurate diagnosis. Now, I want to give you a heads up. I will disagree with you on one thing, that is medication choice. This happens frequently, and that's why people sometimes don't like the psychiatrist. One person's panacea could be another person's toxin. You sit next to each other. One person will swear to God, this medication helped me so much, and another person will look at you thinking that you are the devil because I tried that before and it never worked for me. That can be so contrasting. And what I try to say is, we as a group of the shrink psychiatrists, we do not study one person. Rather, we study thousands of people on the same medication with the same protocol, and we want to see the outcome. And any medication that FDA gives the approval, gives the thumbs up, indicates that they already beat the placebo group and it is useful. Whether this is useful for you or for your loved one is a big question mark. That's why you need to, like see the shrink and let them try it out. And a lot of time, I train the students, I train nurse practitioners, DO students, and PA students. They ask me, what's your trick? I say, I don't have a trick. It's try and error. If it works, it works. If it does not work, it does not work. It sounds very simple, but when you try that, you need to have other peripheral symptoms to lock that in. Wellbutrin is a very motivating medication. It's a medication that can really make you spring up from the chair and make you happy and having energy. However, if the person has a lot of anxiety, the lady asked the same question from the back, and the person is already very anxious, but also very depressed. I give Wellbutrin, the person will look at me saying that you don't know what you are doing. You make me so anxious that I even cannot get out of my bed. But the duloxetine was the bottom. Maybe it's a better fit for them. But for your loved ones, then Wellbutrin is the best fit. So do not make a significant judgment on individual medication until you try that. A careful psychiatrist will ask who in your family has used similar medication, which medication worked better. And based on the other symptomatology, he or she will choose the one that they feel the best. Still, nobody can say this medication will be the best medication for you. I always say this, I have 85% chance to win the argument, but I have 15% chance just to make a fool of myself, because there is always a chance that the medication may not work for you. Now, 85% of the chance the medication can work. If I failed one, I go with the next one, I still have 85% chance to be better. So I said, if you give me the chance to help you, most likely I can help you with a significant improvement. I also joke with my members, and I tell them I'm sometimes like a Western. And I cannot tell you 3 o'clock, the rain will falling down, but it will possibly between 3 to 5 o'clock. So there is 80% chance we will have some rain if I am lucky enough to predict the right thing. In medicine, I don't know the cardiology, neurology, or internal medicine, or infectious disease, but in psychiatry, a margin of error is a norm. What we need to know is very excellent communication at the very beginning. And we treat the person with also respect and carefulness. And the goal is to find the medication that works for your loved ones and work with that for as long as it could. I want to plant the seeds. When you find the best medication for your loved ones, there is also a possibility down the road that medication stops working. It's not just with levodopa or carbidopa, but also with psychiatric medication. But what we are talking about here is years of the stability, but then it will come to the end. And I tell people, think about that. You buy a new car, you have 4 new tires. When it is 60,000 miles, it doesn't matter how good the tire was, you start to have the bumpy ride, and you need to change it. Changing medication, just like the changing the tires of your car, is going to be inconvenient and labor intensive, but it is part of the whole process. I hope that the provider treating your loved ones will share that with you and let you be prepared. I think what we need is not about sugarcoating anything, but accurate information and preferably a concrete strategic approach to ourselves or to our loved ones. Yes.
I'm coming.
I recently read an article on WebMed, I think, PubMed, about on PubMed about K2, and in this, I've been looking at K2 regarding heart disease, but they said that in this study, it was saying that people with Parkinson's tend to have a lower level of serum K2, and so that was an area of possible study. Are you familiar with that? You heard that?
I have to admit my ignorance. I do not even know what K2 is.
Oh, okay, so you have vitamin K.
Oh.
And then the bacteria in the gut synthesize that to K2, but it can be, that synthesis can be blocked by a statin or something else. And so, and it's fine if you're not familiar. So that's, okay, that's fine.
I want to admit my ignorance and paucity of knowledge on that part. In psychiatry, we actually had a long enduring argument or the hypothesis regarding the etiology of the psychiatric condition. Obviously, this is not directly related to Parkinson's disease. And after decades of the research, we still cannot find a very clear causal relationship on many things. And because of that, I try to say that I'm more focusing on the molecule or hypothesis or the theory or the solution that can help my patients directly. I also have patients come to me and say that this, even over-the-counter medication or the condition that has changed is very helpful. In most of the situations, what I will tell you is continue that as it has been, rather than disrupt the stability you have. Whether that stability is a causal relationship stability or it is a peripheral collaborative stability, we don't need to know the details, but make yourself better is the important part. Number one, be safe. Number two, find every way to be healthy. That's generally my rule, sir. But again, I admit my ignorance on that.
So another question I was curious about is psilocybin. So Michael Pollan, he wrote about people getting that for anxiety and being helpful. Is that something that you've been involved with?
I have been reading quite a bit on psilocybin and along with other psychedelics. We actually do one of the very unique service in our private practice that's called Spravato, which is a Kaplan-sponsored or supported treatment-resistant depression treatment. And what the gentleman is really alluding to is the novel mechanism of action and its concrete help to our patients that has been suffering from depression or PTSD or anxiety to a significant degree, that nothing has helped them in the past. And now, with the plethora of the clinical experience and evidence, we know that these the molecules so-called drugs in the past, now can be packaged or applied in the medication format. Certainly, they need FDA approval, and they have a lot more work to do to get that approval. But it is very hopeful that our suffering population can have a solution. I frequently tell my members of the treatment community that sometimes you feel this is the end of the world. You don't see any lights coming to you. You are so depressed, you are hopeless, you feel life is really out of any kind of interest towards positiveness. It's like you're riding on a train. The train is going through the mountains, and it is an S-shaped kind of a railway pattern. You do not see anything coming to you until you really get out of this mountain tunnel, and then suddenly the sun just shines on you. So one thing that I want to say, if I can say that, is do not lose your hope. That's a very important thing. People who have been depressed, people who have been suffering from diseases, do not lose your hope. I also want to give you a positive prediction, and sometimes I get like illusion. I'm psychiatrist, I can do anything that is a little peripheral. I heard from Harvard Public Health School, they predict by 2040, I know that's still decades to go, but by 2040, heart attack, the myocardial infarction, as the #1 killer to our country, that issue is going to be over. Alzheimer's dementia is not going to be bothering the whole community like right now, and nor does the cancer. So 3 things they predicted, but the question is, why couldn't you predict that at 2030 or 2025?
Yeah.
But that is what they have accumulated evidence to project that part. Think about that in the early parts of this century. A lady gave birth to a kid, to a baby. They have 50% chance to die from the infection. Now, that's like a joke. When I was a resident, which means 20 years ago, the AIDS kills people. HIV AIDS kills people. Now that's like a joke. TB has killed so many people for such a long time, but once we have antibiotics, you go with a cocktail and everything will be cured. Why should we lose the hope? As a psychiatrist, I toured the Missouri state capitol, old state capitol. Down the capitol, it was an old asylum, and I still saw, 20 years ago, I still saw the railway track inside of that basement and the segregated kind of chambers. And I was told that in the early parts of the century, before psychiatric medication was available, the crazy people will be chained up and there will be a railway cart being pushed by the nurse, and the people who have been chained up will be fed with the food, and then they dump the water to their body to wash them as a shower. That is so inhumane. One time I was riding an airplane, Southwest airplane, from Tucson to Denver. I think they still have that route. A beautiful young lady sat in the aisle seat, and I was sitting in the window seat. And I was browsing all the medical journals that carries the name of psychiatrist. So she started to ask me, "Are you a psychiatrist?" I said, "Yes, I'm a psychiatrist." And through that 2-hour ride, she poured her personal information to me, telling me about her history as a bipolar patient and her family member's history as a bipolar patient. She wants to get all the information about medication and updated information on that and side effect profile. And as I told her, just like I told everyone else, I cannot give you medical advice. I can only answer that from the factual perspective. A young, beautiful lady was entering graduate school in Denver, in one of the Denver universities. And if she was born 100 years ago, she will be chained up and being put with the water dumped onto her body and be fed with the spoon by the nurses. That's just the error of the timing, that how lucky we are. So never lose the hope when you have a chronic disease situation. One way or the other, somebody in the world is working towards the solution to that. And that could be available way beyond you realize that. It could be really just around the corner. Yes, the gentleman first, and the lady second.
Here I come.
You have talked quite a bit about medication today. What about, is there a good benefit, productive benefit to just talking to a professional, patient talking to a professional like yourself? Just talk. If the patient doesn't have a lot of physical symptoms, it's beneficial just to talk to a psychologist, a psychiatrist. Just counseling without medication. How productive, how effective is that?
It is tremendously effective, and I will say that for this next year, when you organize the series, maybe ask for psychologists to present. I am a prescriber, so I always touch on the medication. As I said and confess to everyone, if my family member has psychiatric condition and if it's appropriate, I will refer to therapists first, the top therapy. I joke with them, I said, you guys use some lip services, and we use some hair services. But at the same time, it can be very effective. There are tremendous of evidence indicating that the psychotherapy is as effective to some type of the psychiatric disorder as the medication without causing any side effect. There are psychiatric conditions that I would highly recommend you take at least combination of the psychotherapy with medication in addition, instead of just talk therapy, such as bipolar disorder, schizophrenia. These are very biologically oriented psychiatric diagnoses, but universally for depression and for anxiety and for the stress-related situation, always engage with therapists. All the evidence indicates the combination of psychotherapy and the medication treatment is going to give far better outcome than medication treatment alone. Yes, it's not easy to find an excellent therapist that accepts new patients. It's not easy, but it is highly recommended. Yes.
One thing that's come up in conversation at our coffee time is when people are in pain or tired, they are unable to function as well as they do otherwise. And it's my hypothesis that that is a reduction in dopamine. Is that a fair assumption?
That's a fair assumption, and in my mind, I think dopamine is definitely one part of the process. There are possibly or highly likely other factors involved with the process, such as the serotonin, norepinephrine, along with endorphin, and it's multifactorial process in psychiatry, and it is very important for us to fine-tune ourselves. As a chief medical officer, sometimes I discuss this kind of topics in the population health level, and I try to say that if we really treat all the anxiety people very well, all the stressed people very well, we can expect that their glucose regulation will be much better, their hemoglobin A1C will be more normalized, their COPD attacks will be far less, their blood pressure goes down, and their heart attacks start to really be reduced. So there are a lot of benefits. We are a human being. Stress is one thing we feel, but we do not really put our pulse on that, which I think we should. And another topic I want to heavily promote is, again, exercise. Everybody should really spend time to exercise. I have a colleague who recently approached me saying that I want to meet with you, but every day, every Saturday from 9 to 11, that's my gym time. I'm sorry, you're off. I don't have a chance to actually meet you for coffee or for anything. I said, I admire that. If possible, I want to know which gym you go to, and I can put my gym shoes on and I could exercise. It's very important to eat healthy, sleep well, and also do regular exercise. Regular exercise does not need to be 5 miles running every day. I know some people do that. That's not my other colleagues. But at the same time, have a regular either the walk or power walk or some kind of a aerobic exercise is going to tremendously help all of us, along with drinking water, not so much of the soda, which I hope that nobody here drinks soda. I'm not against soda, I'm just not favoring soda because there are other problems with soda.
Here's one more.
Okay.
Just one more quick one, Dr. Kai. Bob's had 6 hospitalizations in 2021 to 2022, and my experience has been that there aren't a lot of doctors that are familiar with the treatments for Parkinson's and how to manage those. He was in for infections, eventually got septic, and that's why he was hospitalized. But what's being done to educate those practitioners in the hospital around people with Parkinson's condition? Is there any movement in Tucson at all to do anything? I usually stay in the hospital and I tell people that have, their loved one has Parkinson's, stay in the hospital with them because they don't get meds timely. They don't get them out of bed, so there's no exercise, they lay in bed. They don't want to deal with common catheters. So what's being done for us? Is this something that we need to be working on? What's the health department doing to educate practitioners?
You asked a very, very critical, yet I see I don't have a solution situation. Let me just mention this for my own understanding. After decades of the medical education and medical practice, I realized actually how the American system or any modern country's healthcare system has been set up. It is largely set up based on the prevalence of the disease. Meaning that if you have more people suffering from one diagnosis, the resources to solve this problem is increased tremendously more than if you don't have as many people to have the same condition. For example, dermatology. Why do we have so less dermatologists available when we have so many primary care doctors? The AMA decides the medical specialty based on the frequency of the service needs. And also they are on the conservative side. That's why we have the PAs and MPs to supplement the workforce situation. When we talk about the Parkinson's disease and the specialist in Parkinson's disease, I stayed in 4 universities so far in the medical center medical field. I can tell you, only 2 of them have so-called the psychiatrists specialized in Parkinson's disease. Only 2 of them, and the 2 of them are big research institutions, very big. And because they are big, they are living on the grants, so they can afford to hire the specialist that even does not have enough of the service revenue to support their availability. For the smaller community hospital, I will say that Wenhui is also similar into that level. You may not be able to find a very well-versed and a very well-trained person in that area. They at least have geriatric psychiatric program, and 80% of the effort in geriatric psychiatric program is with Alzheimer's dementia. So think about those situations, because Alzheimer's dementia has a far more prevalence than the Parkinson's disease. And many times the good neurologists will be able, the movement disorder specialists, they will be able to deal with some of the psychiatric perspective or medical perspective, only some of them. Due to the liability issue, nobody will over-prescribe, over-treat the medical condition. That's where I dislike the situation, but at the same time, we're all confined to our own cookie cutter situation. So I can treat a person with depression, with anxiety, with apathy, with impulsivity, with psychosis. But if you ask me to treat high blood pressure or the infection, I possibly won't. I may be able to give you renewal of the medication, but I will engage you back to the specialist that you have been treated with. So that's the default of a very highly sophisticated healthcare system issue. And it's not an easy, so there's not an easy solution to that part.
Deb, do you have any questions from anybody?
I think they've all been addressed.
Okay. Anybody else have a question? Oh, I'm coming.
That's the one last question, so everybody look at the clock and we can do this.
Is there a book you would recommend to help people who have the apathy, who have no hope, who are suicidal? A good book that has tips and tricks and ideas to get people happy.
Thank you very much. That's the share of the information. Am I right? Yes. Is that a question, or is that you want to share the information?
No, I want to know if you recommend a book that could do all of them.
Oh, do I recommend the books that can be helpful? I recommend books, but I recommend the videos and the YouTube information more than the books these days. Everybody learns differently. Some people are very visual learners, and other people are very concrete learners. And I think that we should really educate ourselves from every perspective. The YouTube and the Google research or the PBS information is what I trust. I watched a few PBS topics, and I really feel that number one, the quality, the trustworthy level is very high. They are not promoting any specific product, rather they give you the fair share information. Even though I disagree with the lady about the philosophy and the well-wishing. I do not promote any one of them. I think both medications are actually top-notch medication. So if the presenter has no bearing on what they are presenting, that's what I trust the most. Not like the financial advisor try to get your free dinner, but they want to get your investments from the and so I try to say that find the neutral information, and I also like the presenter to have the concrete experience in their field, not just the presenter, but also really is doing the work as they are doing. So the author, if they are treating the patient, I think that's very valuable. And the presenter on the videotapes that they are treating the people, that can be very helpful. I also realize a lot of excellent, fabulous presenters actually does not treat patients. So for those people, I start to say, well, I'm not too sure. I would rather trust a person who is not well-spoken, but treat people all the time. So the way I talk to everyone here is I always think if my family member has the same condition as you guys are having, how I am going to approach. I would like a surgeon to have the best, the operating table manner and give the best outcome. Even the person does not want to talk to me. Do I want him to talk to me and then give me all the information? Yes. But what I really try to get from the service is the excellent operational outcome. So if he has a track record in doing that part, even if he is a nerd and or very, kind of a surgeon approach person, read me and it's my way or the highway, I would say it's your way, and just go with it. So let's go with the approach. I trust the books, and I want to say that let's get the information from different sources and get the trustworthy information to benefit ourselves and our loved ones. Thank you very much for the
Thank
time.
you, Dr.
Thank you.